musculoskeletal ultrasound definitely it is important. See, ரொம்ப obese இருந்தாங்கன்னா ultrasound waves வந்து skin அப்புறம் subcutaneous fat அதுக்கப்புறம் அந்த லேயரா when it has to pass through அதோட ரெசல்யூஷன் ரொம்ப ஒரு பெனிட்ரேஷன் குறைவா இருக்கும். அந்த டெப்த்துக்கு ரீச் ஆகாது. ஸோ these are all limitations of ultrasound. ரொம்ப obese இருந்தாங்கன்னா imaging சப்போர்ட் நல்லா தான் இருக்கும். It will not be as good as for a thin built patient. Bone details limited, it is almost nil. You will not be able to get some very little bone details also not possible with a routine ultrasound. As I told you, if it is a high resolution, high frequency and expertise ultrasound performing physician irundadunna, then maybe in the tendon injury, bone heal irukka idella konjam information you can get. Otherwise, for our setup where general ultrasound is done, all this is not possible with a routine ultrasound. And last we come to fluoroscopy. So fluoroscopy is mostly diagnosis illama intervention. So treatment assist பண்றதுக்கு தான் mostly we will make use of the fluoroscopy. So this is the fluoroscopy unit. Unit வந்து it's almost like that of an X-ray only. This is இதோட special highlight point of fluoroscopy is real time X-ray images. ஸோ நார்மலாக ஒரு எக்ஸ்ரே, ஒரு சிடி, ஒரு எம்ஆர்ஐ பேஷண்ட்டை படுக்க வச்சு ப்ரொசீஜர் முடிச்சுட்டு அதுக்கப்புறம் we will report the film. இது அப்படி கிடையாது. ஸோ பேஷண்ட் when the x-ray is being done, எக்ஸ்ரே எடுத்துட்டு இருக்கும் போதே they will be monitoring the x-ray images. ஸோ ரியல் டைம் லைவா டைனமிக்கா பண்ணிட்டு இருக்கிற ப்ரொசீஜர் இஸ் fluoroscopy. This is not there in any other imaging modality. Only with fluoroscopy you can get real time x-ray images. And this will give you a high temporal resolution. So angala spatial resolution, the space, the temporal means time. So real time you will get images only with the fluoroscopy. And this common use pannuvanga C-arms. So the orthopedic treatment surgery centers they definitely have a fluoroscopy unit that is called as a C-arm. So on the X-ray tube arm is in the form of a C shape. So that's why we call this as a C-arm. இது வந்து மொபைல் ஃப்ளூரோஸ்கோபி யூனிட்ஸ். யூ கேன் டேக் திஸ் எனிவேர். அண்ட் இதில் மெயின் யூஸ் வந்து அவங்க ஃப்ராக்சரை ரெடியூஸ் பண்ணும்போது தே வில் மேக் யூஸ் ஆஃப் ஃப்ளூரோஸ்கோபி. ஸோ லைவாக பண்ணுறாங்களா, கரெக்டாக ரெடியூஸ் பண்ணுறாங்களா அந்த மாதிரி பார்க்கறதுக்கு. அண்ட் ஃபார் பிளேசிங் இம்ப்ளான்ஸ், ஃபாரின் பாடிஸ் லோக்கலைஸ் பண்ணுறதுக்கு, அண்ட் ஜாயிண்ட் டிஸ்லொகேஷன்ஸ் ரிடக்ஷன் எல்லாம் அக்யூரேட்டாக பண்ணுறாங்களா. ஸோ மெயின்லி இன்டர்வென்ஷனல் பர்பஸ் யூ மேக் யூஸ் ஆஃப் ஃப்ளூரோஸ்கோபி. These are the areas where fluoroscopy is used. So renderedly you can use it for diagnosis and for intervention. So diagnosis la fluoroscopy la joints paakalam. So joints can be assessed. And one more thing, for a dye inject panni adukapra you can assess the joint. That is called as arthrography. So injecting a dye and then evaluating the joint. This arthrography can be done with the fluoroscopy. And then some daycare procedures, I told you, இது mostly intervention related தான். ஸோ ஃபெசர் ஜாயிண்ட்ல இன்ஜெக்ட் பண்ணுறது, நர்வ் பிளாக்ஸ் கொடுக்கறதுக்கு, அண்ட் தென் முக்கியமாக ஃப்ராக்சர் போன்ஸ் ஜாயின்ஸ் ரெடக்ஷன் அக்யூரேட்டாக இருக்கா இல்லையான்னு பார்க்கறதுக்கும் அதை பண்ணும்போது அசஸ் பண்ணுறதுக்கும் we make use of fluoroscopy. Preoperative, perioperative, on the table also they will do fluoroscopy. Trauma related, what are all the surgical techniques where this fluoroscopy will help na intramedullary nailing. So nail screw பண்ணும்போது femur neck oda fractures fix பண்றதுக்கு, physical injuries. Then for spine injuries na screw place பண்றதுக்கு and verticaloplasty. These are all procedures where fluoroscopy will help. So advantages of a fluoroscopy is fast, real time is the most important advantage. Portable, mostly intervention, and 3D technology ஒரு CT அளவுக்கு fluoroscopy கொடுக்கும். Disadvantages, it depends upon the operator. The positioning correct இருக்கணும், factors perfect set பண்ணணும், அப்பதான் நமக்கு optimal image acquisition கிடைக்கும். And patient compliance, this is கொஞ்சம் time consuming procedure, so the patient will have to stay still, breath hold பண்ணி movements இல்லாம இருக்கணும். So patient compliance is important. Fluoroscopy normal X-ray விட அதிகமான radiation involving. So So now that we discussed about all the imaging modalities, advantages, disadvantages, discuss பண்ணதுக்கப்புறம் I told you radiation safety is an important factor. As referring physicians, you must definitely உங்களால where all areas where you can reduce this radiation exposure that you definitely have to, it has to be done. அதனால ARV they call this ALARA, ALARA, as low as reasonably achievable radiation. இது வந்து it's a duty of all of us, referring physician, radiologist and the technical team. So all of us have to work together to bring out this radiation protection. So one of the most essential duties and ethical responsibility of the referring physician and the radiographer will be radiation protection. Patient மட்டும் இல்ல, for the trauma team and for the radiographer himself. So it should be ensured that all of us are protected from unnecessary radiation exposure. So where all that we can do it as a referring physician is you critically evaluate, carefully evaluate the patient. Only if required, you will go for an investigation. See, லேசா கையில எங்கேயோ அடிபட்டிருக்குன்னா you don't even think that bone injury இல்லைன்னா then why do we have to put an X-ray at all? So you do a proper, perfect clinical examination of the patient. Suspicious bone injury இருந்ததுன்னா then we will go for a screening X-ray. Otherwise, we will not even go for an X-ray investigation. Transfer of radiographs to avoid repeat X-rays. See, in most of the places, what happens is இங்க எடுத்த X-ray சரியில்லை, திருப்பி repeat பண்ணலாம். So that can be avoided if it's recently done. கொஞ்ச நாளைக்கு முன்னாடி தான் எடுத்துக்கிறாங்க, this X-ray will give us information, then we can treat the patient based on that X-ray. But of course, ரொம்ப நாள் முன்னாடி எடுத்தது damaged X-ray, then we have to repeat the X-ray. But wherever possible, you can transfer the X-rays. We need not repeat them immediately. Gonad shielding for patients of childbearing age when not interfering with the anatomy of interest. So if a கையில தான் அடிபட்டிருக்கு, ஒரு male patient has an injury in the forearm, you're going to ask X-ray for the forearm with the wrist joint. So then he can use a gonad shield. He can talk to the radiographer and get some shield for his gonads. So if the testis, ovaries are definitely to be protected from radiation. In case ஒரு pelvisல injury அப்படின்னா then maybe that is the area of interest. So அப்போ you can't use protection. If it's elsewhere, extremities na, then you can definitely use a gonad shield. See, this is very important because in the X-ray nala nothing is going to happen for this patient. The age of the patient, when he is in his 20s, அவரோட லைஃப் ஸ்பேன் 60-70 இயர்ஸ் வரைக்கும் the number of injuries இருக்கலாம், எவ்வளோ எக்ஸ்ரேஸ் எவ்வளோ சிடி ஸ்கேன்ஸ் தேவைப்படும் தெரியாது. So every time you expose him to this radiation test, it get accumulated, cumulative response இருக்கும் பின்னாடி. And one important other thing is gonadsல when there is radiation, it doesn't stop with this person. It will pass on to his next generation. So when he reproduces, all this will get transferred. So maximum, where all it's possible, we will have to reduce this radiation dose. So if it's a female patient, they can use lead aprons. Female patients மட்டும் இல்ல, யாராவது நம்மளே assist பண்ண போனோம். So patient is not able to make himself comfortable, he needs assistance, then we will make use of a lead apron for all the personnel that remain in the room during the procedure. So maximum, we will not advise anybody to accompany the patient. வேற வழியே இல்ல அப்படின்னா then we will use a lead apron and then we will do the X-ray. Unnecessary repeat X-rays, that can be avoided. Immediately, திருப்பி எடுக்கணும் இல்லை, you can give them that time. See, if you consider 3 weeks or 4 weeks for healing, the patient is okay, then you repeat it after that. Immediately, உடனே எடுத்து பார்க்கணும்னு அவசியம் இல்லை. So all this time we were discussing about patient with the history is walking into you. OPக்கு வந்து எனக்கு இங்க அடிபட்டிருக்கு, இங்க பெயின் இருக்குன்னு சொல்ற பேஷண்ட்ஸ்க்கு that was the imaging approach. So sometimes multiple, ரொம்ப நிறைய injuries, road traffic accidents இருக்கலாம், இல்ல fall. The patient doesn't even know where he is injured himself. Or patient சொல்ற conscious அவ்வளவு he is not very clear in where he is injured. So that is called as polytrauma. வெறும் orthopedic injury மட்டும் இல்ல, brainல இருக்கலாம், abdomenல இருக்கலாம், thoraxல இருக்கலாம், so organs, anything can be injured. So those kind of polytraumas, 60% of those polytrauma patients will have musculoskeletal injury. Orthopedic injuries are common there. See, orthopedic injuries can also be life-threatening, limb-threatening, or functional impairment. So that is why we are so worried about orthopedic trauma. That has to be diagnosed effectively and proper treatment has to be given. Appropriate imaging of orthopedic injuries is essential to determine the diagnosis and method of treatment. ஸோ அந்த மாதிரி ஒரு பாலிட்ரோமா பேஷண்ட்க்கு இனிஷியல் அசஸ்மெண்ட் நம்ம என்ன பண்ணணும்னா we will have to do a pelvic x-ray. So pelvic radiograph or pelvic x-ray anteroposterior view. Whether the patient complains or not, we can't examine the pelvis. Obviously irukadu pelvisல swelling o edo. So we will do a pelvis AP view because அதுதான் முக்கியமான ஏரியா. Femur head can cause severe bleeding that can be life threatening. So important area will be a pelvis x-ray. So we will do a pelvis x-ray AP view. Plain radiographs are the standard and most cost-effective imaging modality for screening and characterizing bone injuries. And pelvic radiographs will be integral part of the initial evaluation of the patient with multiple injuries. Why? Because pelvic ring fracture that sometimes can be life-threatening. So on the time we will not go for a CT pelvis. Why? Because already we are in an emergency situation. Polytrauma நம்ம முதல்ல assess பண்ணனும், evaluate பண்ணனும். இப்போ first எடுத்துட்டு போய் patient CT ல விட்டோம்னா it is a time consuming process. First ஒரு screening, x-ray we will do. We will assess the pelvis. That is okay. Patient hemodynamically stable இருக்கறாங்க. Everything is fine. Then we will slowly do the other injuries எங்கெல்லாம் இருக்குன்னு அதுக்கப்புறம் நம்ம evaluate பண்ணலாம். So we will not consider pelvic CT. So do not consider pelvic CT as a substitute. So அவ்வளோ ஒரு pelvic x-ray எடுக்கிற அளவுக்கு நம்மளால ஃபாஸ்டா அந்த ப்ரொசீஜர் பண்ண முடியும். Shifting, appointment, everything can be done very fast. Then think of a pelvic CT. Otherwise, we will do a pelvic x-ray AP view. And then additional radiographs of the extremities. This can be done after you evaluate. So extremities நம்ம evaluate பண்ணலாம். See if there is swelling, pain, tenderness, deformities. So அந்த மாதிரி இருந்ததுன்னா then there may be a potential fracture or a dislocation. So you first see if the patient is hemodynamically stable. That is important. All his vital parameters are okay. Pulse, BP, respiratory rate, good. Then he doesn't require any urgent operative treatment. அது ரெண்டையும் satisfy பண்ணதுக்கு அப்புறம் we will do the extremities evaluation and then we will do the radiographs. So generally they'll call this as rule of twos. எல்லாம் ரெண்டு பண்ணுவாங்க. So 2 views, 2 joints, 2 limbs and 2 times. 2 views, basically I told you earlier itself. So sometimes ஒரே ஒரு standard view எடுத்தா x-rays can be missed. So ஒரு AP, ஒரு lateral. So most of the bony parts, it will be AP view and a lateral view. Anteroposterior view, lateral view. Hand to wrist to mattum, we will go for a postero-anterior view. Because it is passing from top dorsum to down. So hand to wrist to it will be a PA view. Almost all the other parts it will be AP view, anteroposterior and a lateral view. So rendu views எடுத்துட்டோம். Obtain 2 views for the injured limb depending upon the area involved. And then 2 joints. So general rule is to obtain radiograph of the joint above and below the injury to rule out any potential associated fracture or dislocation in the corresponding joint. So one reason is to see if the fracture has involved the joint. Second, to see if there is a joint subluxation or a dislocation. 2 limbs, இது routine கிடையாது. Only when there is a limb length discrepancy. Limb ஓட lengthல ஏதாவது comparison தேவைப்பட்டா then we will do 2 limbs. Radiographs of the injured and the non-injured limbs. This is made to aid in evaluation and diagnosis of certain injuries, especially important to aid in determining the limb length. So limb oda length la discrepancy irukku, inequality irukuna, then we will do comparison x-rays. 2 times obviously, one before the fracture treatment and second is after you reduce illa kattu pottadukku appuram then we will do the second view. So adukappuram actually pelvic x-ray, extremities x-ray and other investigations will follow like how we do it for a normal. So ஒரு மசில்ல ப்ராப்ளம் இருக்கா பார்க்கணும்னா ஃபர்ஸ்ட் ஒரு அல்ட்ராசவுண்ட் ஸ்கிரீனிங் பண்ணலாம். அதுல தெரியலனா then we will do an MRI scan. So CT எப்போ பண்ணனும், MRI எப்போ பண்ணனும், we already know. The same approach should be followed even for a polytrauma patient. Pediatric trauma. So mostly adults இருக்க மாதிரி தான் pediatricலயும். One thing I told you is incomplete fractures are common that you can have in mind. Second is radiation factor. Children, radiation is very important factor that you have to consider. Before you ask for investigations, choose wisely and then you decide on the investigation modality because radiation is very more so for the females of reproductive age group and pediatric. So அதே மாதிரி ஒரு female of reproductive age group வந்தாங்க it's not an emergency X-ray, then you can wait till she crosses the ovulation period. So if it is around the 14th day of her cycle, regular cycles, she's planning for a pregnancy, avoid X-ray exposure that time. If it is an elective X-ray, it can be done later. Of course, trauma நம்ம அது பண்ண முடியாது. So let it போட்டுட்டு we will expose the females of reproductive age group for any X-ray procedure. So likewise for the children also. And இன்னொரு important consideration for a pediatric X-ray is the bones of nature. Growing skeleton. So அது ரொம்ப pliable porous தான் இருக்கும். So this is more, they are more prone for what is called as growth plate injuries. So what is this growth plate? So growth plate இன்னொரு பேர் வந்து epiphyseal plate or simply physis. இது வந்து ரொம்ப important in pediatric injuries. So in the growth plate அந்த ஏரியா வந்து it is a cartilage area, ஒரு long boneல அந்த cartilaginous part of that long bone is what is growth plate or physis. This physis என்னன்னா high metabolic activity ரொம்ப ஜாஸ்தியா இருக்கும். So அந்த growing bone ஓட length and the height, all that is being given by this growth plate. Because the growth plate, it helps to determine the future length and shape of the mature bone. This type of fracture will definitely require immediate attention. So physeal growth plate injury இருக்கா இல்லையான்னு நம்ம rule out பண்ணணும். With proper treatment, most of these growth plate fractures will heal without any complication. So if it is not attended properly, அப்போனா then this child can develop a crooked limb or ஒரு கால் ஷார்ட்டா injured normal leg விட ஷார்ட்டா இருக்கிற மாதிரி இருக்கும் injured leg. Why? Because the growth plate injury has happened. So in the bone la, the top part is the epiphysis. Epiphysis is the area which is closer to the joint. Epiphysis ko metaphysis ko இடையில இருக்கிற அந்த ஏரியா தான் physis for the epiphyseal growth plate, or simply we call this a growth plate. That red area is called as the growth plate. So in the growth plate injuries, ரொம்ப ஸ்பெஷலான இன்வெஸ்டிகேஷன்ஸ் இல்ல, all that we have already discussed, but you have to have in mind அந்த ஏரியா epiphysis-க்கும் metaphysis-க்கும் இடையில இருக்கிற ஏரியா இன்வால்வ் ஆயிருக்கா இல்லையா, that part you have to do. So routine plain x-rays, அதுதான் ஃபர்ஸ்ட் பண்ணணும். plain x-raysல you can add, that is by anatomical landmark. fracture ஓட descriptionல என்ன anatomical landmark mention பண்ணணும்ங்கிறது because of conditions like this. So we have to know where this fracture is happening. Epiphysis-ல metaphysis-ல அது கிட்ட இருக்கிற ஏரியா வரணும்னா then you must think of this growth plate injury. routine plain radiographs போதும். அதுல தெரியலன்னா oblique radiographs or comparison x-rays. And x-rays will தெரியலன்னா then we will do CT scan. CT scan and MRI scan have equally good for physeal plate. See, இந்த growth plateங்கிறது ஒரு cartilaginous area. So இது வந்து CT-லயும் நல்லா பிக் பண்ணலாம், MRI scan-லயும் நல்லா பிக் பண்ணலாம். So this will be used to map the percentage of total amount of the growth plate which is involved in the injury and subsequent disturbance of the physis. So physis injury pick பண்றதுக்கு this will be the approach. So first you do x-rays, இல்லனா then CT, and then அதுக்கப்புறம் you can do an MRI. So this is the normal appearance of the physis. So bone மேல இருக்கிறது epiphysis, metaphysis-க்கும் epiphysis-க்கும் இடையில இருக்கிறது தான் physis. That is the growth plate or epiphyseal plate. First picture it looks normal. Second injury la வந்து across அது கிட்டவே parallel there is a injury. The second type la below the growth plate there is an injury. That red line indicates injury which is below the growth plate. And fourth type la from the growth plate upwards மேல இருக்கு injury. And the next type will be across மேல through the growth plate and கீழ. That is the fifth type. Fourth one. The last one is growth plate crush ஆயிடுச்சு. So this is a classification called Salter-Harris classification. முக்கியமா for pediatric epiphyseal injuries. இந்த growth plate ஒரு விஷயம் தவிர மிச்சபடி எல்லாமே is common for adult and pediatric bone. Thing is, radiation has to be considered while you choose your investigation. So that is the summarizing of all the investigations in orthopedic trauma. So X-rays will give us details about the bones. You can use it as a screening tool. First injury, history with the patient, you do a clinical diagnosis, you do a radiography. And then CT scan. Excellent bone details, axial views. So this where you will use for spine, pelvis, acetabular injuries, tibial plateau injuries, must கண்டிப்பா ஒரு தடவை CT evaluation பண்ணணும். And pre-operative. நீங்க treatment முடிச்சிட்டு you are referring the patient for a surgery, then you do a CT evaluation and then you refer the patient. MRI, this will give you complete soft tissue information. And second important factor to be remembered is bone edema. MRI will tell you about bone edema that will help in diagnosing occult fractures, stress fractures. Ultrasound is for a soft tissue screening. I would say muscle hematomas, joint effusions, and the other areas you can use ultrasound as a screening procedure. Fluoroscopy is mainly intraoperative, intervention related. So, nammaloda diagnosis we might not use fluoroscopy that much. So, mostly when he plans for a surgery and the reduction accuracy, nail pandrathu, screw pandrathu, adukkaga mattum we will use fluoroscopy. And one important point with fluoroscopy, which is not there with the other modalities, is real-time imaging. As the procedure is done, you can do a imaging. So, with this, I summarize the imaging approach for orthopedic traumatology. I thank you all for your patient listening to this long session. Thank you, sir. And my special heartfelt thanks to Varmam Department HOD and the faculties for giving me this opportunity to share that little knowledge that I have about orthopedic trauma and its imaging approach. I hope there have been some points which you can apply in your clinical practice. Thank you. Thank you, sir.
Thank you, ma'am. It was an excellent presentation. I request Dr. M.B. Mahadevan, sir, HOD, Department of Puramarthu, to share a few words regarding the presentation. Please, sir.
Good evening, one and all. Extensive presentation regarding imaging techniques, and highly we are incorporated and we are getting help from the madam for the, especially we are having the OPD of the injuries and fractures and so many things, and we get a lot of doubts during the patients came with the X-rays and CT, MRI. We used to get an opinion very cordial, and there was no ego. People, many modern people are working here. There is no ego with that. We are constantly getting an opinion, and sometimes she tells that, sir, this is our opinion. You may get a second opinion also, sir. This is the very important way of speaking in a scientific platform. Thank you, madam. And then she tells one by one. That is also the chronological order. The X-ray, how much it is necessary, and then the CT, and then the MRI. The soft tissue injuries, the MRI is very important, and the difficulties which is faced by the patient. I have faced just now. One month back, I had undergone MRI. They kept me for 1 hour. It was very terrible. Not only the claustrophobic, it was head irritated. If it is in the, then they know that there is an open MRI. I'm not bothering about the some things, but steps to be taken, especially in the pediatric and the childbearing ages, whether it is necessary or not, everything step by step she explained. So people, you may sometimes, some of the medical officers may have a broad experience and reading the radiological films, that you can share your views. Otherwise, if you have any doubt, any queries, you may ask. Anybody is having
any questions?
Any questions?
From the participant side?
No.
I think they are very clear, ma'am.
It's very excellent.
Yes, ma'am. It was a very wonderful
really,
presentation.
thank you. on behalf of Department of Cerebral Orthopedics.
Thank you, one and all of you. Thank you, sir. Thank you. See, you may feel free to have your doubts cleared anytime. You have some doubts with the insights of these imaging modalities in your approach. You may feel free to get it cleared anytime. Thank you.
Thank you, ma'am. Is there any question? I request Dr. M.P. Mahadevan sir to honor our resource person, Dr. Sharnali ma'am, with a certificate and the memento. Please, sir. For 10 minutes and please assemble within 10 minutes. Thank you. Other doubts will not get up 4 minutes away.